My name is Tina Reed, and I am currently on the Family Nurse Practitioner track. Upon completion, I plan to become dual certified in adult gerontology acute care. My nursing philosophy and worldview align with the nursing paradigms. I believe each person is a capable, autonomous partner in their healthcare, and that a person's environment, including family, culture, and community, shapes their beliefs about their healthcare. Health is a person's belief in well-being that changes with life and stress, and it is a nurse's job to help people reach their health goals by teaching clearly, removing barriers, and finding what works. I will respect their choices, be fair, and keep care safe and manageable. This presentation will show how a combination of nursing theories enables the advanced practice nurse to help patients manage their self-care needs. Orum's self-care deficit nursing theory identifies the gaps between what care requires and what a person can do. Eakes, Burke, and Hainsworth's chronic sorrow theory reduces emotional barriers so people can keep up with their daily self-care needs. Bandura's social cognitive theory centers self-efficacy and confidence as the method for adopting and maintaining self-care behaviors, and Betham and Mill's utilitarian ethics chooses the self-care plan with the greatest overall benefits and the least burden of harm. Together, these will help me assess, intervene, and evaluate care that complements my philosophy and worldview. Orum's theory holds that nursing is needed when self-care agency is less than the therapeutic self-care demand. She asks, can a person do what the plan requires? Following her steps, I have chosen to use an adult new-onset insulin-dependent diabetic case scenario. To implement her theory, we start by assessing basic conditioning factors and self-care agency. We gather data on skills, knowledge, motivation, support, and context, then specify to the patient all required self-care actions. This helps us determine therapeutic self-care demand. Once we identify any self-care deficit, we compare agency versus demand to locate exact gaps. This helps us decide the most appropriate next steps. Next, we plan the supportive educational interventions that are either partly or wholly compensatory based on the gap, such as plain language teaching, demonstration with return demonstration, a written action plan appropriate to the patient's health literacy, and collaboration of resources. Next, we implement teaching and practice into manageable steps so that the patient doesn't feel even more overwhelmed. We help coordinate services and then attempt to remove barriers. Finally, we evaluate and revise as needed by rechecking skills and confidence, adherence to the regime, laboratory values, goal outcomes, and any complications or emergency contacts. This aligns with my philosophy and worldview because it sees the patient as a capable partner in healthcare management and decisions, it makes barriers visible and actionable, and it aligns with the nursing paradigms. In my advanced practice role, I will structure my visits around Orum. During intake, I map agency versus demand. During education, I use plain language, teach back, and return demonstration. In follow-up, I review skills and confidence and barriers consistent with health literacy guidance and the diabetes self-management education and support standards. I will judge improvements based on fewer glycemic episodes, improved hemoglobin A1C, fewer urgent contacts, and stronger self-care efficacy. Eakes, Burke, and Hainsworth theory of chronic sorrow. This theory holds that ongoing loss brings recurring emotional waves that can disrupt daily living. It asks, how can we normalize the waves, teach coping, and schedule support before hard moments hit? This theory says hard feelings return in waves after a big change, be it ongoing loss or a chronic illness. In this patient scenario, first we want to rule out acute grief or major depression, so we start by assessing for patterns of chronic sorrow. We need to identify what has changed, anticipate when the waves of sorrow will hit, how strong they will be, and how they can affect the patient's sleep and routines of daily life. Next, we name and normalize it so it makes sense, explaining its recurrent nature and acknowledging the meaning of the loss. Care then focuses on planning ways of coping, support, and management, co-creating one or two usable strategies and scheduling check-ins around anticipated triggers, such as social gatherings, clinical setbacks, insurance hassles, public injections, and stress related to work or family. Finally, the response is evaluated over time, adjusting the plan as needed to ease distress and to help daily life work better. In alignment with the nursing paradigms in my worldview, Eakes, Burks, and Hainsworth theory of chronic sorrow sees the person as living with ongoing loss or change, experiencing recurrent emotional waves. The person's environment, consisting of family, culture, routines, alarms, anniversaries, and clinical events, are seen as support and triggers. And the person's health is the adaptive functioning over time by managing distress, new role identities, improved clinical outcomes, and sleep patterns. And finally, nursing offers anticipatory guidance by helping name the pattern, normalize it, teaching coping skills, and planning support over time. Betham and Mill's utilitarian theory of ethics. This theory asks us to choose the plan with the greatest benefit and the least burden. It questions, is this option manageable for patients and families? Utilitarian reasoning selects among clinically acceptable choices which safe option helps the most with the least hassle. It starts by defining the decision and the stakeholders, then compares feasible options by weighing real-world factors. Next, it chooses from and communicate the plan with the highest net benefit in plain language and discuss anticipated burdens with patient-focused manageable adjustments. And finally, you monitor outcomes and revise the plan if the benefit is not apparent. In clinic, I define the decision and who's involved by having the patient decide between option A and option B to achieve targeted goals while minimizing burdens. Next, I compare clinically safe options using real-world trade-offs such as cost, complexity, schedule, literacy, access to care, and psychosocial load. Next, we choose and communicate the highest benefit, lowest burden plan in plain language with literacy appropriate instructions, and I document and monitor outcomes. For example, improved hemoglobin A1C, fewer hypoglycemic events or emergency visits, less distress, better sleep, and stronger self-care confidence. If something isn't working, we go back in and revise the plan, implementing cost help, simpler logging tools, or community resources to keep the plan fair and doable. With utilitarian ethics theory, the patient's goals and values define what counts as benefits and burdens. The environment includes real-world constraints of cost, time, literacy, work schedules, transport, and access to care, but also it benefits from family and community support. Health, again, chooses options that maximize overall benefit and minimize burden among safe alternatives. And finally, nursing offers transparent reasoning, shared decisions, and proactive burden reduction. Integrating theories for advanced practice. For advanced practice, the self-care deficit theory, chronic sorrow theory, and utilitarian ethics work as one complementary framework. Orum's self-care deficit answers what self-care tasks the plan requires and where the person needs supportive educative help. Eakes' chronic sorrow theory answers when predictable emotional waves will disrupt self-management, so coaching and check-ins are time before triggers. Utilitarianism decides which safe option delivers the greatest overall benefit with the least burden, enabling us to remove barriers like cost and complexity. Used together, advanced practice nurses can move from assessment to manageable interventions, producing real results and improved ethical clinical outcomes. Bandura's social cognitive theory finds that behavior change is driven by self-efficacy built through modeling, small steps, and feedback. It asks, how can we build confidence for self-care management? The steps of Bandura's social cognitive theory are the roadmap for the clinical plan. Bandura says that confidence drives action, so we determine how confident a person is for each step and find out what gets in the way. Mastery is built through small, successful steps. We then demonstrate the skill, have them try it, and set tiny goals. Modeling and encouragement make the progress feel real, and the use of quick feedback shows improvement and helps calm nerves. Ongoing reassessment maintains the behavior, and if confidence or technique declines, we shrink back the steps, practice again, and keep what works so the new behavior sticks. For a new insulin start, I first target the behavior and tasks that we need to address, such as drawing up correct insulin doses, injection techniques, site rotation, and treating hypoglycemia. I have the patient rate their task-to-task confidence from 0 to 10. We then design for small mastery wins where I show it, they try it, and we set tiny weekly goals focusing on the lowest scores. Additional learning through brief real-life modeling or peer examples, and we use specific credible praise to build self-efficacy. For example, your injection angle and 10 count were spot on. That's exactly what prevents leaks. At the next visit, we review the goal, celebrate the wins, and adjust the next tiny steps so that this confidence and accuracy keep building. With the social cognitive theory, the person takes an active role in their learning and actions. Self-efficacy drives their behavior, adoption, and maintenance. The environment includes family and caregiver support, home routines, and meal patterns, as well as their ability to maintain mastery in a variety of settings, such as their work, school, and social events. Their health is maintained through this mastery of skills, consistent behaviors, fewer safety events, and clinical improvements. And finally, nursing is responsible for modeling, developing graded steps, and providing encouragement with rapid feedback. In advanced practice, nursing theory provides a structured ethical pathway from assessment to intervention to evaluation. I will demonstrate how my chosen theories and ethical framework assist advanced practice by balancing benefit and burden, aligning plans with patient capacity and context, and documenting rationales, then verifying outcomes and revising as needed. When we assess, the self-care deficit asks, what can the person do now and what do they need to learn for insulin? Chronic sorrow asks, when do tough feelings or stress spikes show up? Social cognitive asks, how confident do they feel doing each step? And utilitarian determines which options make the most sense given time, cost, and life. When we intervene, self-care deficit wants us to teach it, show it, practice it, give a simple written plan, and needed supplies. Chronic sorrow tells us we should time support around hard times, normalize feelings, and teach 1 to 2 quick coping skills. Social cognitive theory uses small wins, sets tiny step goals, models the skills, and uses quick feedback. Utilitarian asks us to pick which bundle helps the most with the least hassle, write down why, and reduce burdens. And finally, when we evaluate, self-care deficit asks us, are they doing the steps correctly and needing fewer urgent calls? Chronic sorrow asks, are tough moments easier to handle? Are they getting better sleep or are daily routines back on track? Social cognitive asks, is confidence up and the step goals being met week after week? And utilitarian asks, are the results better overall? Are they having more time in range, fewer lows, lower A1C, and less distress? Bringing it together, I've demonstrated how the self-care deficit theory shows what to teach and support so the plan is actually doable. Chronic sorrow highlights when emotions will make self-care harder, so we time coaching before these moments. Bandura explains how to make new habits stick through smaller steps, modeling, quick feedback, and specific phrase. Utilitarianism helps us choose which option truly helps most with the least burden and to remove preventable hassles like cost and complexity. Integrating these frameworks, I can deliver high-quality, ethical, and equitable advanced practice care by turning assessment into targeted action, safer techniques, fewer hypoglycemic episodes, improved hemoglobin A1C, less distress, better sleep, stronger confidence, and improved patient satisfaction and clinical outcomes.